If health and care is meant to be built around people, why do patients so often feel like they're an afterthought? This is Behind the Breakthrough, the podcast where leaders behind the UK's most complex transformations reveal what actually drives breakthrough change. Today I'm joined by Jacob Lant, Chief Executive of National Voices, the coalition of more than 200 charities working to make sure lived experience actually shapes health and care in England. He spent his career pushing the system to listen harder, think bigger, and stop mistaking process for progress. From almost a decade leading national campaigns on everything from maternity, mental health, social care, NHS dentistry, he's shaking up how we listen to people and the most vulnerable. So grab a coffee and let's find out what it takes to turn ideas into impact. Jacob, you run one of the most important patient voice organisations in England, but a lot of people won't have heard of National Voices. What is that organisation and what is your role in that?
Essentially, we are a coalition or a movement, if you will, of a whole bunch of different charities working in the health and social care space. So we've got about 200 members split into two groups effectively. So we've got those who focus on conditions. So your sort of cancer, diabetes, dementia, classic what you'd think of as a health charity. But the other half of the membership are charities that focus on particular communities, often those who have poorer outcomes and experiences of services at the moment. They could be recent migrants, it could be people affected by addiction issues, homelessness, older people, all sorts of different community charities coming together. And we sort of try and merge those two wings of the party together to make politicians, policymakers sit up and listen, involve people from those charities in decision making to try and make services better.
And do you think the government, public sector generally does a good job in listening to those charities? Where would you put them on a scale?
When it wants to. So when they've got an idea to do a thing anyway, so they want to come up with a new national cancer plan, they will do a good job of involving cancer charities in the development of that plan. If it's on something that's not on their agenda, it's much harder. And actually, that's where you have to find the balance between the two. When are you going to be helpful to an existing agenda, and when are you going to have to push government and decision makers to say, no, you've missed the point here, or you've overlooked this really important issue, and how hard do we push them? So so it's on their terms, they're pretty good, but if it's not, it can be much harder.
So they're kind of reactive to needs rather than proactively kind of looking at your organisation, charities there.
Yeah, it can be. Yes, have to sometimes force them to sit down and realise what's really important to people.
Yeah, and in a weird way, how do you then make sure the voices of those charities and the most vulnerable do get heard? Because they can be lost, they might not have the access to the tools at their dispense to actually lobby to government or get their voice heard. How do you help them with that?
So I think a lot of that is based on helping people understand the tactics and the things that result in change. So that's making sure that they've got combinations of hard data and evidence to back up their campaigns with strong stories, user-led, so lived experience stories, putting the users front and centre of their campaigns. And often for us as a coalition, it's about finding the cross-cutting issues. So it's what is it that unites cancer patients with diabetes patients, with older people, with migrant communities? What is the cross-cutting thing that makes them much stronger as a united voice and harder for government and the NHS to ignore?
Okay. So you know about people, their voices, patients. If you were to take a pulse of the nation right now about how they're feeling about the NHS, what would you say about that?
Well, on the one hand, I don't need to take the pulse because others have recently done this. So people listening might be familiar with the British Social Attitudes survey, which is done every year, sort of described as the gold standard of surveys about sort of public attitudes towards the NHS. And in recent years, we've seen positivity about the NHS plummet. I think that's the only way of describing it. And last year, it hit rock bottom. It was the lowest it had ever been in the sort of 20 odd years the survey's been running. I think even longer than that, maybe 30 years. It hit 20% satisfaction for the NHS. So it tells you the public are not happy with where the service is. Now, the new results that came out a couple of weeks ago, it's gone up a little bit to 26% satisfaction. That's still pretty low. It's still historically very, very low. So I think you can see on the surface level, the public are not pleased with where the NHS is right now. But I think the diagnosis that leaders put on that is different to what's going on. So what's actually driving that dissatisfaction is probably very different in reality. So I would say NHS leaders, the government, have decided that it's the size of the NHS waiting list that is making people unhappy. Fundamentally, I don't think that's the case. I think it's user experience of waiting for a hospital treatment is what's driving dissatisfaction. So it's the fact that I go for a referral with my GP, and then I hear nothing, or I might get a letter saying, your referral's been accepted, we'll see you at some point, and then I go into this vacuum where I don't hear anything. Meanwhile, my condition is getting worse. I'm not getting any help to manage my condition. I may well be seen in the timeframes that NHS has set out. But for me as a user, it feels pretty miserable. And I think it's that dissatisfaction with the experience of waiting, not the size of the waiting list, that matters. And I think that's why, so the survey tells us satisfaction is low, but the reason for that, I think, is often misunderstood by policymakers.
Okay, that's really interesting. If we dig down into that, so if I read it right, it's the uncertainty about the waiting period, the fact that you're not getting any information, you don't know what to do. That's the thing that's causing the issues, rather than the fact that we have to wait a certain amount of time, because that's almost universally accepted. You're going to have to wait for treatment.
Yeah.
It's that period. Is that right?
Yeah, exactly. So I did a piece of work. This was pre-pandemic, so it's a bit dated now, but people waiting in A&E departments, and whether they were seen in the 4-hour window or not. And overwhelmingly, the response is, if I'm seen in 5 hours, but someone is keeping me up to date on what's happening to me, I can see kind of moving along a pathway, I've got access to food and drink whilst I'm waiting, I'm not worried about the parking running out on the in the car park, all those sort of factors. I might be waiting longer than the government wants me to wait, but the experience of waiting is pretty good. I know what's happening to me. You can wait 3 hours and no one is talking to you at all. None of that additional support is offered, and you are much more likely to be very dissatisfied with the service. So you're seen faster, but the experience was worse. Yep. So I think there's sometimes where we focus too much on the time bit for patients and less on the experience. And actually, if we focus more on the experience, we could probably improve satisfaction across the board.
That's interesting. You just remind me of something Rory Sutherland, one of the kind of famous marketeers, said.
Yes,
yeah, about the taxis and why Uber's successful. So what Uber did was it tackled the uncertainty that people feel when they order a taxi about when it's going to arrive and how much it costs by just making it super clear.
Yeah.
You still have to wait the exact same amount of time, but the experience is just better because and that uncertainty goes away.
Yeah, absolutely. And you can have direct application of that in the NHS world. Take patient transport as an example. So patient transport, you might be booked in for that, and they'll give you a window of when they're going to pick you up and take you for your appointment. But there's no certainty about when it's going to arrive in that window. And that window can be quite a large window because they're going around picking up lots of different people. And I remember when my grandma was having patient transport services, she basically, at the start of the window, well, actually probably half an hour before the window, she'd get a big coat on and sit on the stairs waiting for that to arrive. But she could be sat on the stairs for 3 hours in a coat waiting for and the anxiety then of not knowing where it is. Now, I'm not saying my grandma would have got out her smartphone and looked at her app and seen, tracked where it was. Yeah. But there's that kind of that uncertainty of whether the service is going to turn up drives a lot of the dissatisfaction.
You've been so passionate. I can tell the emotion that you bring to the table. What made you kind of choose this kind of career, this course? Was there a particular moment? Was it just decisions you made? What gets you so kind of enthused about this topic?
There's no plan to my career trajectory. I mean, like most people, you just end up in roles by accident. But when I look back, I can kind of see a thread that goes through it of maybe these were the things that motivated me. If I take on my first job working here in health and social care, I actually it was a temp job in a summer between years at university, working for a local authority in their in an occupational therapy team. I was doing equipment orders for people who are having home adaptations and equipment and things to help them live independently. And I spent a lot of time on the phones talking to service users and carers who were putting orders in and requesting assessments and things. And you got a sense of like just how much of a burden the system was on them to manage. And then internally, I remember I did very strongly this piece of advice that I was given by my manager, which was, if someone rings you up and asks for an assessment or some equipment, and ask them, are they still in hospital? If they are still in hospital, tell them to speak to the NHS occupational therapist, because if they speak to the NHS, they'll pick up the tab. They'll have to pay for everything. So the advice from my manager was, I now need to tell the user to go and manage the situation so the costs lands elsewhere. And that felt deeply, deeply wrong from my perspective. And I sort of you think about how many times are we putting the burden on the user to manage this bureaucracy that we've created, and I just thought that's not okay. And maybe that early experience was I've got to be in roles that challenge that sort of injustice and that sort of unfairness that's put on people who need our help, rather than infighting between services about where budgets are spent.
So just talking about people who are vulnerable, people with complex multiple conditions, people who might not have English as their first language, etc., people who are homeless, what are the barriers that the system, if you like, puts in place, either actively or unknowingly, that prevents them from getting access to the care they need?
Well, it designs the service entirely for the services, from the services point of view. So mental health services are a really good example here. There's to say, well, if you can, maybe not true everywhere and not as true now as it was, but if you can have your crisis on a Wednesday morning at 10 o'clock, that'd be great, because that's when your appointment is. Dealing with the complexity of people's lives is really tricky. So people affected by homelessness, they might have addiction issues, there's a lot of chaos going on in their lives, a lot of uncertainty, and often health is not their number one priority. They've got other things that are more immediate pressures. And so actually, how do we design a system that works around, that's flexible for them, that is open for when they might possibly need to use the service, is very different to, I've got a contract of X number of appointments that I can deliver in this time window. So if you're a service manager, how you think that through, and we've got a lot better in the mental health space, but I think, that concept is true across the NHS.
Can you bring it to life? Can you give an example where actually we have designed or redesigned services to really fit around the user and how that's benefited them?
So I think in part the move towards remote appointments is gone half of the way there. So I think there's a lot of angry news articles in some tabloid newspapers about, I want to see a GP face to face. Actually, the vast majority of people are quite positive about seeing a range of different healthcare professionals through remote platforms, because it's more convenient. I can have a telephone interview or a Zoom interview with my GP from home, from work, whatever. It's convenient around my life. That works for a lot of people who are just busy generally. It works for people who are in rural communities who don't have to travel particularly far or might not be able to travel far. It helps people who maybe have physical disabilities, who struggle to travel to appointments. So something like that has worked quite well as a way of designing a service that has solved some traditional problems. But what we then do is we only go half the distance. So what we've done is created that accessible way of having an appointment, but the system says it's on our terms. So you can have a telephone appointment with your GP, but your GP is going to ring you at some point today. Whereas before, you'd be told you'd have an appointment at the surgery at 3 o'clock. So it's much harder to now organise your life around, at some point today, someone is going to call me, and I'm going to have to just juggle with that around whatever I'm doing, rather than saying, actually, they're going to call you, and they're going to call you at 3, please be at your phone. So we sort of half designed it, half got it right, and then you do something else that then makes it more frustrating, which is why then you see people get annoyed at remote appointments. It's not the mechanism, it's the way that we've delivered it is the problem.
Okay, this is a really fascinating conversation. Can I give a devil's advocate position?
Please.
So you said patients, or the tabloids, if you like, often complain you can't see a GP face to face. And that might be the view of some or many patients, when in reality, what you're saying, actually, a lot of people would be comfortable with seeing them virtually at a convenient time. Do patients and customers always get it right in terms of expressing what they want? Because sometimes what they say isn't always what they actually mean.
I mean, there's a phrase, isn't it? The customer is always right, I think.
Which is half the statement in
Well,
matters of taste.
Oh.
There you go.
Well, fair enough. I think the point is about offering people choice and control at particular moments, so they can have agency and control over what's going to happen to them, and we try and take choice and control away from them. So again, one of the reasons why. So it might be that the patient didn't really know whether they wanted a face-to-face appointment or a remote appointment, but if you offer them the choice and you're talking through at the point of booking the pros and cons of different routes, you could say the same about the type of professional that you see in a setting. So give the example, I call my GP surgery, or I'm on the online form booking, and I say, this matter is not urgent, I'd really like to talk to the practice pharmacist. I'm exercising some choices there, and the practice can respond to that. But I know quite a lot about the system, so I can get what I need out of it. If I don't know, because I haven't spent my life working in health and social care policy like an absolute nerd, then how do you design the systems to offer those choices to people, to prompt them to make the things that were choices that might be right for them at that moment in time, and you give them control? And I think that helps, and I think that gets us to the point where they might not know how serious or urgent something is, but we can help them come to that decision by giving them the right tools and choices.
Okay, that's fascinating. So because of the way that we present the choice through potentially a lack of information, uncertainty about the choice itself, that actually skews people into making almost a decision, an ill-informed decision, if you like.
Yeah.
Like, no, I just want to see it face to face because I actually don't understand what it means to see a virtual GP.
Which is why you get people still wanting to see a GP face to face a lot of the time, is even if it's less convenient for them, they are more familiar with that interaction. So they keep going for that because we haven't made the other interactions better and more attractive to people. Yeah. A good example of that would be GP surgeries moving everything to book your appointments via online forms, right? So they blanket put that in place, and some practices went to the extent of they won't take bookings over the phone, or if you wander into the surgery, try and make a booking at the desk, right? They actually said, no, we don't do that. We've been told everything has to go through the online system. And it's just like, well, that's not responding to the need that's in front of you. It's not offering people choices. And actually what I'd do is I was like, well, yes, you can book over the phone, but did you know it was easier to book online? You can fill that form out at your convenience, whatever. So, and that's what private sector's done. You take banking, so like they've gone slowly over time. They've gone, it would be easier for you to do that thing via the app, and we've got people used to the idea over a long time of what you can do in banking with tech. In the NHS, we just expect people overnight to switch like that. So now we're digitally enabled. Book your appointment online. Yep. Oh, we've cut off all other routes for you to book appointments because we'll force you down that route, and people hate it.
Okay, interesting. I think there's this term referred to as the choice architecture of how you lay out a set of decisions in order to nudge people into making a better and more informed decision. And almost what you're saying is slightly revolutionary in the sense that small changes to the way you provide information can actually have a massive change. You're not saying we need loads of money resource to make this change happen. We just need to make it slightly clearer, almost with these smaller interventions. Is that right?
Exactly. I know a lot that you said in the introduction to this, I've been challenging the system to think big. Actually, I've been challenging them to think small. So what's the really small things that you can do that will make an impact on experience, will generally make people feel like the NHS cares more about me and is thinking about me and what I need, and that sees the bump in satisfaction. People get better outcomes, and they are better enabled to look after themselves.
And do you think, therefore, we're measuring the wrong things? Because if we're measuring wait times, we're measuring average wait times, etc. Do you think we're measuring kind of the wrong things? Because unless you cut the wait time, you failed. Whereas we're not really measuring wait time experience and things like that.
Yeah, I mean, there's the whole concept of you can hit the target and miss the point, and I think that's what we're doing at the moment. Well, we're missing the target and missing the point. I think very much we're measuring the wrong things. For me, if I was to redesign the system from scratch, I would put patient experience and outcome measures as the highest order KPIs for the system. Like, your output measures and your financial measures are the things that get you to the outcomes and experiences at the end of and so there's your indicators along the way, but they're not the judge of success. You haven't done a good job if you've hit your financial controls, if you've left half your community untreated, right? That is a bad job that you've done, and yet we will reward people who hit the financial controls. Likewise, just delivering outputs, you could deliver lots of. I had this conversation with a policy team in Number 10 many years ago, was they were asking about how you could hit the government's the Times commitment around the number of GP appointments increasing. And I said, well, you could cut all GP appointments from 10 minutes to 5 minutes, and then you'd hit the target. But you would have you'd have wound everybody up, GPs, patients. You'd have just like messed up the whole system. You'd have hit the target, but you'd have missed the point. And so I think we do measure the wrong things, but we measure what's easy to measure.
Trust in healthcare data has become a real fault line. How did we get to a position where millions of people and patients are afraid of sharing their healthcare records? They kind of don't want to share things. How did we get to that, and who's to blame for that?
Big question. I mean, firstly, I don't think people are scared about their health data, their health records being shared. The question is, who's it being shared with and for what purpose? So on a basic level, people want their records to transfer between their GP and their hospital seamlessly. They don't want to get to their hospital appointment and the consultant doesn't know anything about the referral, or they aren't able to access the notes, or they kind of miss this really important part of the patient's journey, and so they're not prepared for that moment because they don't have the information to hand. There's an expectation that should just be happening seamlessly, and it doesn't at the moment. Right? We don't have a single patient record. We're going to have a single patient record, hopefully, but we're not there yet. So that causes a lot of frustration for people. So kind of people want it to happen, but it's not happening. And then on the other hand, we're saying, oh, we'd like to use your patient data for research purposes. We'd like to share it with pharma companies, with tech companies, in order to improve innovations in health. And people go, well, hang on. Like, you're using it again for your purposes, which I might see some benefit from at some point in the future. I might access one of those innovative treatments, but I might not. Meanwhile, you can't share my data effectively between my GP and my consultant, so my time is wasted. I have a poor experience. So I think that's at the crux of the issue, is that we're trying to, as a system, use patient data for things that people can't really grasp why it should matter, whilst the thing that matters to them we're ignoring. That's how the user perceives it. And I think then you get other issues around mistrust and use of data creeping in, because we haven't fundamentally got that deal right with people.
Okay, so there's mixed messages, basically. So there's a lack of clarity around why we need your data, what are we doing with the data, where is it going?
Yeah.
Again, going back to that point you made earlier about, because it's ambiguous, because we don't know, you can then assume the worst.
Yeah, you can assume the worst, and someone who's peddling messages about the worst happening, they gain traction, and that gets gains media attention, and you start to get sort of misconceptions about what is happening with data creeping in. There are legitimate concerns, but sometimes that gets there are things out there that suggest stuff is happening that definitely isn't going on.
And do you have any suggestions? Because sometimes people talk about patient choice and empowering patients to make their choice. Yep, if you want to share it and you want it to be used for stuff, let's make it a patient choice. Versus, actually, the NHS is there to provide direct care to people. We already have patient data. We should be using it for their benefit, which is kind of, you're almost balancing the two out, because one is demanding that data for certain use, and one is saying, no, we should give it as an option. Where do you think?
Well, the current rules around this is like, if you want to do data sharing for direct care, you don't need consent from the patient to do that. And I think that's a very sensible situation to be in, because the NHS needs to move the data around to be able to provide direct care. Yeah. The problem is when you stretch the definition of direct care, and you pretend that research is direct care. That's where you enter mistrust. I also think there's questions like the opt-out, the national data opt-out was took a long time to develop, but that does give patients some choice over how their data might be used. It's limited choice. It's a very pragmatic and practical way of managing choice, but the choice is there. So if you want to opt out of your identifiable data being used for planning and research purposes, you can do that.
Yeah.
And I think that's fundamentally a good thing. And if you look at the lots of polling's been done over the years to find sort of public attitudes to data sharing. And that opt-out is really, really important to give people the choice. Not many people exercise it, but it's important to have the choice. Yeah. The problem is every time we have a scandal in data sharing or we get it wrong, is the number of people opting out spikes.
Yeah.
And the more people who opt out, the less valuable the data set becomes. The challenge for the NHS is to get the comms right and the policy right to rebuild trust. So that sort of opt-out it goes up and down. It does. It's not a sort of continually increasing number of people who've opted out. You've got to re-win people's trust in what you're doing.
Okay. And on a slightly different topic, technology itself is seen as a little bit of a panacea. It's going to solve the problems that we have in the NHS, in public sector, across industry. And if you look at the 10-year plan, one of the phrases that really stuck out was reform or die. And one of the key enablers of this is science and technology.
Yeah.
Do you agree with that? What are your thoughts on technology?
I fundamentally, it is true that, because the whole world is changing because of the way that tech is developing. So they sort of fundamentally go hand in hand. Reform of the NHS. It's going to have to make the best use of tech. Can you rely on tech alone? No, I don't think that's a sensible decision. I think the 10-year plan is very, a colleague of mine referred to it as very pro-robot. And it's this idea that the robots are going to save us. And I don't think the public necessarily trust that at the moment. They don't trust that in AI. They don't trust that in tech generally, particularly when tech goes wrong and people get stuck out of this, they're blocked by the technology. They want access to humans still. I did poll years ago a question: would you rather be treated by a fallible human or a compassionate robot? Right. So the idea the robot never makes a mistake, but it won't offer the human touch. The human makes mistakes, but they'll give you the care, like the caring bit of care that you need. And people overwhelmingly still choose the human. They don't choose. They're more confident with a human making mistakes than a robot that is that is sound, but they don't trust that interaction. So you're going to have to move a little bit at the pace of that. So yes, tech is essential to the plan. You're going to have to modernise, but we over rely on tech at our peril, and I don't think it will save the money that people think it's going to save at the moment.
What are your thoughts on AI and its transformational impact today and in the future?
So today, it's funny because we're doing a piece of work. It's not funny. It's very serious. We're doing a piece of work at the moment on looking at attitudes to AI amongst particularly marginalised communities and what their concerns might be. I think there's a desire at the moment to make sure that there's always a human in the process somewhere. Yeah. That AI, people are keen to see it used and adopted, but as an assistive technology. They don't really like the idea of AI being the decision maker. And there's a kind of a concept that people are more comfortable with AI being used on lower, what they describe as lower risk interventions. So auto-transcribing conversations, appointments, is seen as a lower risk thing. So people are more confident with that than they are, say, AI being used to make decisions about scans and the likelihood of cancer. Now, actually, my view, my own personal view of this, is there's more risk in the ambient voice technology recording conversations than there's in the scan. The scans are more sort of, you take the kind of the technologies that are already being deployed in looking at scans. They're very, very good at ruling out the ones that are definitely not cancer, for example. Mm-hmm. So they only leave the hard stuff that humans can get involved in. Whereas the ambient voice technology stuff, there's plenty of small errors that could creep in that create issues in the long run for how a patient's journey builds up and how clinicians are engaging with them. So I think it's almost like we've got the narrative wrong. We're saying this stuff is low risk, don't worry about this over here. This stuff is the whizzy stuff. You should this is the piss, and it's actually the other way around. And I think that matters. So then, how people experience tech, we need to build the trust in the whizzy stuff, and we need to point out kind of where are the dangers, what you should be looking for in what feels basic. So I think that's where we are with sort of AI right now, and that human in the process is so critical to get right. AI for the future, I don't think it's much different to that, really. I think you've still got to go through that process of building trust. You've got to, I mentioned about the sort of co-production, you've got to involve people in the design of these systems and make sure they're comfortable with them, make sure they know when AI is being used, and give some sort of concrete promises around it. And I think that's going to be true now, 10 years, 50 years, 100 years' time.
And so just to use your example, so do you see AI getting better over time to the point where some of these little, if we call them niggles, will then be overcome? So AVT, ambient voice technology, will capture things really clearly and accurately. And therefore, it does make sense to invest in that technology, learn from it, etc. now, because we know that in 3, 5, 10 years' time, it will become kind of part of the course. Or is it actually, we need to be a fast follower, we need to wait and see, let's make sure it's established, the trust is there before we then go forward and adopt?
That's so difficult. I mean, this is why you involve people in that journey, because people have different views, right? Some people will want to see those technologies are perfectly safe for every community and have considered every different angle before you roll them out. Other people were like, well, we're going to miss out on opportunities that we could achieve right now if we were a bit braver in testing things. The problem for the NHS has got is that its tolerance for risk is really low, because when things go badly wrong in the health service, it's not you get like, I don't know, a delivery company drops something on your doorstep and breaks it. That's not like in the NHS, it's life and death, isn't it?
You talked about risk tolerance. Sometimes we forget that staying where we are right now, there is so much risk in that already, and sometimes we don't recognise it. If we just go back to the single patient record, we actually don't have the connected data right now, so people are making decisions on that, and we're kind of stalling because of these concerns, when really we're not recognising the kind of position we're in right now and the risks that involves.
Yeah, it's like pretending as there's no risk in the way that we do things at the moment. Exactly. We absolutely have risk all the time. You could take something like discharge summaries is a piece of work that we've been looking at recently. So AI being used to support resident doctors produce discharge summaries for patients, and is that a good or a bad thing? And it sort of there's one school of thought that's like, well, actually, we need to. Is this replacing the role of the doctor? And how can we make sure it's safe? But there are also resident doctors who are really tired, right? They're humans. They're going to make mistakes in how they produce those discharge summaries. They're going to have other pressures on them. They're going to get through them quickly in order to get a patient out so you free up a bed. Actually, if you've got technology that can help them with that, great. It's not necessarily safe what they're doing at the moment. It's not zero risk what they're doing at the moment. At the same time, if you don't, there's another argument. If they're not doing the discharge summaries, if the tech takes over, is that an important learning skill that we're losing from the resident doctor's journey? Is that something actually that's integral to making them better doctors? Is actually having the process of forcing you to go and do that? I think about this in my earlier career, like in sort of comms roles I was in. I've seen comms people come through now using tools like Grammarly. Mm-hmm. And they just accept all the changes that Grammarly puts into the thing, even if the changes are nonsense. Grammarly's kind of misunderstood the point. Is there a risk that doctors will do that, or they'll kind of lean on the technology more and just because they're going to be busy doing something else?
And do you think there's a cultural piece here? So, anecdotally, driverless cars have
my favourite topic.
Have a much reduced accident rate than human-driven cars. However, if a driverless car was to have an accident, it would be completely unacceptable for that to happen. Yet we'd accept a 10x type risk if a human was driving, and we'd kind of be okay with that. How does that come into play with these kind of things? You talked about the human versus the compassionate robot, even if the compassionate robot was basically right all of the time and us choosing human. Is that right? And do we need to change something culturally?
I don't know. I mean, we haven't got the answer right with driverless cars, have we? Like, who's to blame if the driverless car crashes? Is it the technology, the kind of like making the driver's car happen? Is it the car? Mm-hmm. Is it the passenger for not assuming control at the right time? Is it who is liable? We haven't really answered those questions. So when you put that into the health context, who's liable? Is it the resident doctor? Are they assuming liability because they're the ones signing off the form? Is it the AI and the considerations it's gone through? Is it the manufacturer of the AI? Is it the trust that's chosen to purchase that AI tool? I don't know. We've not got the answer to that. But I think that culture will change. But again, that's why you have to involve people in that journey. You can't just make assumptions about this stuff. Mm-hmm. We have to go on that journey together and make those trade-offs together. Otherwise, it won't work.
And on the topic of trade-offs, a lot is said about the digital divide in the UK. Mm-hmm. There are people who get technology, have it on their phones, have all of these different chatbots, etc. And then there are people who might not even have a phone, might not really engage with the internet, the vulnerable, etc. So there's definitely a divide. How do you see how we bridge that digital divide in the age where we are generally moving towards more technology-led services?
It's a real challenge, my main concern is that we put people into two camps: digitally enabled and digitally not enabled, right? And it's much more fluid than that, because you might have people who've got smartphones who know how to use them, but they can't use it for the purpose we want them to because they don't have the money to have the data, right? Or it might be that somebody is used to using their smartphone for one piece of technology. We make assumptions they'd be happy to use it for another. So a grandparent using WhatsApp to video call their grandkids is very different to that same person using video conferencing technology to speak to their GP. Yeah. We make the assumption that just because you can do a video call, you can do it regardless of the audience. They might not be comfortable with it. We also make assumptions that young people who have grown up with current technologies are somehow they just love all tech and they want it all of the time. Actually, when you engage young people, they're probably one of the more skeptical audiences about how tech gets used in the health space. So I think we can't have this binary view that we've got some digitally enabled and digitally disenfranchised people. Also, the idea that doesn't, I think we've got an idea in our heads that that's fixed, that at some point everyone will become digitally enabled. It will become so cheap and so commonplace for everyone that will disappear as a policy issue. I don't know about you, about how, as you get older, whether you feel as comfortable with technology as you did when you were in your teens, for example. I personally think that digital disenfranchisement, digital exclusion will continue to change as technology changes. It's just a fundamental nature of humans, right? So I think that all matters in terms of how we understand the digital divide. How we actually bridge that, again, is about involving people, kind of understanding what is acceptable to them, but also thinking about, I might give a practical example here. So registering at your GP, they now want all registrations to be done via an online form, right? Some people can do that, some people can't. There's a commitment that practices will offer analog support to people to fill out those registration forms. Now that takes a variety of different formats, but one I witnessed that I thought was really nice was a GP practice. A person went in to register and they said, you can fill out the form on this iPad, or I can fill it out for you. Would you like some help? And that's a really nice proactive support. It doesn't really matter what reason somebody might have for not being able to fill out the form. They might not be comfortable with the technology. They might not speak English. Their literacy levels might be low, whatever it might be. But by the proactive offer, you destigmatize somebody's ability to engage digitally in that thing. That's a small change in how we make that offer, but it's those small changes all connected together in how we think about tech will make an important bridge in the divide, I think.
Interesting. So there is a technology, if I can say this term, technology-first approach, but with support, so that no one gets left behind. I think it's a really interesting observation. You will always have a divide, the kind of really digitally enabled versus the people who don't necessarily want to connect to it in that way. And that will continue even if we're all really digitally savvy. If we keep pushing at this digital-first approach and not necessarily considering the impact on the most vulnerable, what do you think the worst-case scenario is in 5-10 years' time?
An expansion of the two-tier system that we already have. We already have communities who are, you can clearly see in the data, have poorer experiences and outcomes at the moment. They wait longer for treatment, and there isn't really a good explanation as to why. I think the risk is if we don't involve them in the design and the tech, they'll continue. That'll get worse, and I think the mistrust will grow even further as a result. So I think that's the risk. So if you take something like the elective backlog, like kind of the waiting list for hospital treatment,
Yeah.
it's only last summer as if we started to as NHS England started to publish the data broken down by different key demographics. But we've known for a very, very long time that if you're a woman, if you're an ethnic minority, if you live in an area of deprivation, that you wait longer for treatment. But that has only been surfaced by charities and think tanks surveying, doing additional analysis, kind of trying to build the evidence base. Whereas the NHS has been sat on that evidence internally for years and can see it, but it hasn't routinely published it. It's not challenged on it. And I think actually by putting that stuff into the public domain, we're able to scrutinise and say, have you really considered who you're seeing and who you're not seeing? Because that's the thing that will matter to how you manage the health of whole communities, not just managing the demand that turns up at your door. And so that critical thinking and having the data to support that critical analysis is vital.
This is a really interesting conversation about technology. So why don't we go hypothetical for a moment? So imagine we're redesigning quite an analog service at the moment, NHS 111, to give an example, and we're fast forwarding it in 10 years' time. Let me paint that picture, and then let's talk about the pros and cons. So 10 years' time, call handlers don't exist anymore because they're replaced by AI-enabled call handlers who follow rules really well, who are personified, so they have emotion, compassion. They don't break any rules. So they follow a kind of predictable script, if you like, and they're able to have a really nice conversation with patients based off millions and millions or billions of different calls that have happened previous. Is that a good thing to be happening in that space? Is that not? What are the pros and cons?
Oh, I don't know whether I think that's a scary view of the future or not. I guess at the moment, we don't really know. People aren't really asking the questions about how comfortable people are with that sort of technology. So we can't really know how people would respond to that. And I'm interested in the journey of how you might get to that world and how you might still offer people who are not comfortable with that route a different choice. So, imagine that, you ring 111 and you're offered a choice. You can speak to the AI call handler now who can deal with as many calls at one time. There's no capacity pressures on it at all. So you get straight through and they can handle the initial inquiry. Or you can choose to speak to a human. That's an option still. I think that should still be there. I think in 10 years we still won't be a world where people are completely comfortable with the robots being in charge. So, that seems to be an option. People can then choose, but they might have to wait for the human to answer. I think that's probably a fair trade-off to offer people at that first point of call. I think if you're talking about AI replacing the clinician, who's the second stage call, I think that's a much trickier subject to get into about how comfortable people are with that, what the risks are associated with that. So I think there are ways that you can design the service in co-production with people, talking about what options we might trial and testing and sort of nudging people to a world where it's slightly different. But you would also need to continually work with people in communities to evaluate that change. Is it giving people what they want? What are the unintended consequences? Have we made the service worse? Is it not as effective? Or is it more effective? We don't know. We haven't got the technology to try yet. But the process you get there is almost as important, if not more important, than the actual end result for me.
Do you think, though, just to play the devil's advocate view, do you think we're just way too hesitant to even explore those type of opportunities because we just write them off completely? There's no way you could change all of the call handlers because you want a human in the loop, you want a personal experience. What if the computer gets it wrong? Whereas if you have AI, you have potential benefits of it's quicker, it's faster, it's more safer, etc., etc. And sometimes that just gets ruled out, like without any discussion or debate.
That's why, again, you have to involve people in that process. You can't, and you need to be transparent about that. And there are trade-offs. There will always be risks. There's risk in everything. There's risk in sticking with there are plenty of people who are waiting for 111 to pick up or don't get the response in the time frame that they need it. And so, there is risk that we have in the current system. So, but if you're piloting things, if you're taking people on that journey with you, involving them in the trade-offs that they're willing to accept, they're the ones, and that the groups that you're involving are also reflective of all the communities that might need to use the service, we can come to the right answer. Technology will move us forward. You look at human history, it will do. It's inevitable, but the way that we do that matters.
And do you have a view on the workforce impact of things like technology and AI? Because one of the negatives, if you like, of AI and other things is it's going to be a mass workforce replacement. People are going to lose their jobs. That kind of thing is always kind of put out there. Do you have a view on that?
So I think potentially it does have the potential to replace certain roles in the health and social care context specifically. But we've also got so much work to do and not enough health professionals. I think the workforce that we've got is probably pretty safe. It might get redeployed to different things, but I think it's pretty safe, and so the work won't change. I don't think the jobs will go. You've got some questions there about the type of work that they'll do. Mm-hmm. So take the AI scans, the AI analysis of scans, for example. It weeds out all of the ones that are clearly not cancer. It's very good at doing that. It then just leaves the doctors to look at the scans and say the kind of the judgment call ones. So you've gone from now, that might have been 10% of scans you looked at previously, to that's now 100% of scans. Every single one is a heavy decision-making process. How much of the human brain can actually take those really complex decisions? Is that good for a clinician, or do they need that's clearly not cancer scan as the kind of a way of managing the difficult decisions that are going on? And you might see that sort of change in work, kind of the pressures. One of the other things I think is around the cultural changes that will happen. In the 10-year plan, there's a lot of talk about how you can use technology to empower patients. You can give patients more tailored information about treatments they might be entitled to. That could be translated into different languages, different literacy levels. Patient could be better prepared for interactions with clinicians, and that's great. But right now, you can do some of that via Google and other solutions. But if you turn up with that in a clinical setting, it's often not greeted as a positive thing. So are we equipping clinicians with the appropriate skills to be able to support empowered patients? Or are we building a world where patients are going to be more empowered, clinicians are going to feel more busy, and there's actually you create tension because you haven't equipped people, the clinicians, with the right skills to operate in this changed environment?
And do you think there's a cultural piece? Having travelled a little bit around the world, attitudes towards technology and just technology progress vary massively. Some people are super willing and kind of see it as almost like a sense of national pride. If we're moving forward, we're using the latest technology, etc. And then you've got other cultures, especially in Western Europe, who kind of see this with a sense of skepticism. Do we need to move away from that skepticism to a more, actually we see the benefit, but we need to do it safely type approach?
Well, I'll give a practical example of this because I was at an event where lots of tech companies were demonstrating their latest medtech solution. There was a company there, I can't remember the name, but they had an app on your smartphone that uses the camera. You can take a picture of a skin lesion and it tells you whether it's skin cancer or not. Yeah. And it's pretty accurate in doing that. And they were adamant that people wanted B2C communication on this stuff. They wanted the application to test it there and then, and they could know. Yeah. I was like, I don't think that culturally sits particularly well at the moment with most segments of the community in this country, wider Western Europe, I don't know. But the idea that at 2 a.m. I'm slightly nervous about that skin lesion, I'm going to take a picture and it goes, you've got skin cancer. I'm not like, what do I do to process that piece of information on my own at 2 a.m. without access to anything else that's going to help me kind of understand what that might mean, what my treatment options might be, how much do I believe the tech. So there's lots of things you need to provide as wraparound care to make those. Just because you can do something with tech doesn't mean it's necessarily a good thing to do, right? And I think we need to think about all the wraparound support that makes that stuff acceptable and deals with the culture that we have in this country. That might be that we're a little bit more risk averse around this stuff, but there are reasons for that, and they're innate in us as a country, so we can't ignore that, and you can't re-educate the whole public to just be happy without that thing. It's not going to happen. It's a reality of adopting the tech. So I think, just because you can do stuff with tech doesn't mean you should.
That's fair, and I think it goes back to your point around tech with support. So there's technology, great, but actually you need a bit of wraparound support to help support with that. I think that's a really valid point. You're in charge now, Jacob, of the entire NHS and the service. No rules, no governance, no bureaucracy, nothing exists. What would be the first big change that you would make to services to improve them for patients?
So I think there's probably two. I would do a structural change and I'd do sort of an operational change. So if I was completely in charge of everything, I would create a national care service for social care. Most of the problems we see, the terrible problems that exist are the poor integration of services between health and social care, and the user being put in the middle of that and trying to navigate that and end up fighting with different services to connect them around them when they are unwell, they're struggling to manage their conditions, they've got a lot of pressures on their lives. So actually, if you had a national care service that was on the same equal footing as the NHS in terms of prestige, in terms of the way it was funded, the way it was perceived by the public, I think that could make a huge difference. It would be free at the point of use, some of the same principles for the NHS. I mean, how you fund that is a big question, but I'm not actually in charge. So, but I think that would at least, it puts us in a position where the two parts of the two services that fundamentally help people live their lives when they've got health and care needs are working together on an equal footing around the user. So that's the structural change I'd make. The other change, the more cultural, sort of operational change I'd make would be about changing the measures of success. So those two services working together would be judged on the outcomes and experiences of the users. They are the highest order things that we should measure. Ultimately, from a politician's point of view, that's what the electorate's going to vote on, their experience and outcomes. They're not going to vote on how many hospital appointments have been delivered. That just doesn't make sense from a voter point of view. It's actually my experiences, my outcomes, and is that going in the right direction? So if you put those as the highest order measures, above finances, above outputs, above all the other KPIs we have in the health service, that would culturally drive a different way of thinking in the NHS and in social care, that the user is put at the centre. It would stop the phrase patient-centred care just being like a meaningless buzzword. I heard a colleague, I think, I forget the name, but they worked at Macmillan. They were speaking on a panel, and they said, they used the analogy that bullfighting is very bull-centred, but it doesn't necessarily end well for the bull. And so that's like when you say patient-centred care, you get the same sense in the NHS that, yes, it's patient-centred, but it maybe doesn't end well for the patient in the way that we've got it designed at the moment. And I sort of love that idea that if we actually had metrics around experiences and outcomes mattering the most, we would be forced to engage people in understanding why they're not getting the outcomes that they need and the experiences that they want. What they said would matter more than how we design services. We'd have to involve them routinely in the design of every service in order to hit the headline targets. So I think that's the sort of the cultural driver that I would want to introduce.
And traditionally, or just on the outcomes point, traditionally, outcomes are quite difficult to measure. They're not measured as much as things like activity or episodes. What would you change in the way we measure outcomes, and what specific things would you might measure?
So, I mean, it's a good question, a really good question, because you say the word outcomes and everyone in the NHS world always nods, goes, and then you get a strong sense that they all have a slightly different interpretation of what an outcome is. Yeah. And obviously I would approach this from the user perspective. So has the intervention that we provided allowed you has it managed your pain effectively? Has it enabled you to get back to work? Has it enabled you to care for a loved one? Has it added years to your life that are quality years of life? Those sorts of things that really matter to the user, rather than, yes, it was a successfully completed heart bypass. Great, that is an outcome, but it's not really the end outcome that we're looking for. We're looking at that heart bypass has led to someone being able to run around after their grandkids, right? So I would measure outcomes from the user perspective and put them at the highest level, and that will upset a lot of people in the system because it's not perfect as a measure. Yeah. But for me, it would drive a cultural change that I think would make a huge difference.
And one of the things you mentioned offline, which I found really interesting, was this concept of the drop curb theory and how we can apply it more to health and care. Do you want to explain that a little bit and what you mean by that?
Yeah, so I think a lot of the time we start as a default position and we'll design a service for the majority, and then we'll be able to use the money that we save from that more efficient, digitally enabled mass system. The money will then target that money towards the people who are underserved at the moment, who are getting worse outcomes. The reality is that's never going to happen. That money will never transfer. Just the accountancy will never work in that way. So I would flip that and say, let's design a service very specifically for the people having the worst access at the moment, the worst experiences, the worst outcomes, and try and find the things in there that benefits everybody. So, take if you take online access or through the app, for example, if you're designing the app for people who've got particular communication requirements, so they don't speak English, or they're BSL user, or they have physical dexterity issues that mean interacting with the app is a problem for them, or they can't see the screen. If you design the service for them, I don't understand how any of the changes for those groups are going to make my life harder as someone who doesn't have those needs. Like putting something in plain English is really good. Putting something in that's got a literacy level of, sort of an 8-year-old, I can read that. But actually, if that makes it easier for lots of other people to read it too and understand what's going on, that sort of stuff matters. So design it for the people having the worst experiences, and you build in a lot of things that fundamentally make life easier, like drop curb theory. So, vital for wheelchair users to be able to get around, but also very helpful for people with buggies, delivery drivers, my kids on their scooters, it just benefits everybody to have that sort of thing and doesn't make anyone's lives harder. So I think the more that we look for those sorts of ideas, the better.
So moving to a different part of the interview about your predictions, what do you think will happen going forward? Do you think over the next 10 years, we will increase our co-development with patients, listening to patients, designing services around them more? Or do you think we'll kind of be stuck in the kind of middle way, halfway house that we are in today?
I genuinely don't know the answer to that question. I think we are at an inflection point on this sort of stuff. It's interesting because people might say it takes longer to involve people in the process. It's more expensive. It's going to slow things down. That may be true to some extent. It's not that expensive, really, in the grand scheme of things. This stuff we don't invest enough in it at the moment, but it is peanuts compared to the overall budget. So if you take the budget for Healthwatch, which is the independent statutory champion for patients, their budget is less than 0.001% of the overall spend on health and social care for the whole thing. So it's like we spend absolutely nothing on this stuff. So it doesn't make things more expensive. I've never seen it make anything worse. I've never seen any engagement exercise fundamentally make a program worse. I've only ever seen it make it better. I've seen it stop bad ideas. And I've certainly seen plenty of things developed without co-production and involvement of communities that then got stymied by judicial review later down the process because it hadn't followed the statutory duties or the right sort of consultation processes. So in many ways, it's a shortcut that if you make it, it's going to come back to bite you later. Yep. So either in a judicial review or in just the fact you've designed a service that doesn't work because you didn't understand what your customer actually needed,
And over the next 10 years, what are the macro level trends that excite you and also kind of scare you?
I think this idea that you can do mass engagement replaces the need, and the idea that individuals being empowered to speak up replaces the need for sort of collective voice and involving people in processes. Feedback alone is not enough. So I think so that's the macro trend that worries me. Mm-hmm. But I think that with technology and with a kind of a shift towards more deliberative democracy, I think you're seeing this government. There are opportunities to say, actually, these communities are missing out, and we can do deeper engagement with them. These are the voices that we're not hearing through feedback mechanisms. So if we have a genuine commitment to those deliberative democracies approaches, I think there is an opportunity that co-production can survive and thrive in a world where you've got this sort of transactional model of feedback over here, but you still recognise the value of co-production. In a more sort of pessimistic view, this one's cheaper, so that's the one that gets picked, and we need to make sure that we're challenging that. And that's why it's so important to have some sort of independence to any function around gathering patient feedback and what it's playing back into the system. If it's not independent, I think there's a struggle that communities won't trust it, that it won't be able to challenge the system, it won't be able to say, are you using the right methods for the right engagement for the right purpose?
And final question. the next guest who's going to sit in your seat will be a leader within the public sector. What message would you give them?
Think deeply about your last interaction with the NHS as a user, and think about how that worked or didn't. Doesn't matter how big or small the thing was, but think either what's the thing that you want to amplify from that you would want every service to do, or what's the one thing from that you think maybe if I wasn't me, I might have struggled with that and I need to challenge that. So think deeply about reflecting on your own personal lived experience can be a really important driver. It doesn't have to be the thing you talk about publicly, but it can be a really important driver in actually being compassionate, being empathetic about how other people experience services, think about how we've experienced it ourselves. And so I'd really challenge them to do that.
Thank you, Jacob. That's it for this episode of Behind the Breakthrough. It's been a really eye-opening conversation with Jacob Lant from National Voices. It's a reminder that in digital health, measuring the right things like experience and outcomes is fundamental. When patients have both choice and information, we get better experiences and better outcomes for everyone. And when we design systems with the most vulnerable in mind, we actually raise the standard for all. As I reflect on this conversation personally, I'm reminded how we can use our own experiences more to shape the way we tackle challenges, to put ourselves in the shoes of patients even more. Real progress happens when we co-develop with users, not just design for them or to them. Thanks for listening, and join us next time as we keep exploring how to make digital health truly work for everyone. See you next time on Behind the Breakthrough.
People shouldn't have to pull out their own teeth, should they? And then that was it. I was like, oh God, how bad was that?